we now have a growing number of systemic treatment options for patients. For many years now, we've had sorafenib, which has been proven to improve survival. Dr. Bruges, one of his seminal contributions. And now even with second-line therapies. And it's been said to get patients a second-line therapy, you need to get them to first-line therapy. And in order to get them to first-line therapy, we need to have a robust patient. Arndt, can you comment a little bit about first-line treatments and managing some of the side effects?
Yeah, so I think for first-line treatment in the last 10 years, we just had one drug available, that was sorafenib. And I think this was a clearly positive trial, and we had good evidence and reasons to use sorafenib. So at that time, there was no second-line option. So, and I think this was also one of the reasons why there were like two, first of all, I mean, when we use sorafenib, we have, of course, as we do it in all other tumor types, we have to manage side effects. So indicating specifically with sorafenib, I mean, these patients are not used to systemic therapies. They have these underlying liver disease. They might be more sensitive to side effects. They have additional problems through the tumor and through the liver disease. So these are patients that need careful monitoring. And in general, I think when we start systemic treatment in these patients, we have to monitor them very closely. So you can't go and give them the drug and say, okay, come back in 3 months and we do the testing.
I think that's a great point, because drugs like sorafenib, now regorafenib, lenvatinib, these are oral drugs.
Right.
They are not chemotherapy, they're molecular targeted therapeutics, but they're anti-cancer drugs, and you don't just say, you know, take and I'll see you in a few months.
Right, these are oral drugs, so the patients do not require to come into the hospital, but still the side effects develop. So we have set up some measurements to really monitor these patients very closely. So when we start treatment, we see them after 2 weeks again, then after 4 weeks, so, and we really educate them about their side effects. And then
specifically, what are you looking for?
Yeah, I mean, specifically when we start treatment with sorafenib, I mean, we have fatigue, diarrhea, hand-foot skin reactions, and those are side effects we really would like to control very early on, and we don't want them to develop to grade 3 or 4. So I think it's really critically important to make adjustment to the treatment very early on, also to bring the patient through the treatment. So therefore we need to see them and see and discuss with them what kind of side effects might occur. We need to monitor them, and if they occur, we need to do early dose adjustments, and maybe also to increase the dose again once the side effects have been resolved.
So starting a patient 400 milligrams twice a day, which is the studied dose, and they may need a dose reduction, but you're saying if things get controlled, you would even consider going back to the...
Yeah, I mean, so I think there are two ways how to start treatment. I mean, and we had the discussion also with regorafenib, whether you start with full dose or you start with a reduced dose. I think if you start with a reduced dose, you have to keep in mind that this was not looked at in the clinical trial. And of course, you are not allowed to forget to increase the dose if there are no side effects. If you start with a full dose, you have to do the early monitoring to see whether the patient develops any symptoms, which might lead to too early stop of treatment. So I think either ways are possible. In general, I would stick with sorafenib to start with a full dose, do the early monitoring, and do dose adjustment once side effects occur.
So we're monitoring for toxicity, right? Another important thing is monitoring for efficacy,
yes,
right? And we know from numerous studies that have shown that sorafenib consistently gives us a survival benefit, which arguably is the most important endpoint. Mm-hmm. But it doesn't necessarily shrink tumors,
yes,
right? And it's not chemotherapy, it's not cytotoxic. How do we know the drug's working?
So I think this is the point we have discussed before. So here with sorafenib, I think we can accept stable disease as a good and efficient outcome. So as long as the patient has stable disease and the tumor is not growing, I think I feel good to continue with the treatment. Within the trial, there was a composite endpoint, and there was also clinical deterioration as a marker to maybe continue or stop sorafenib at a later point as beyond radiological progression. I'm personally not sure whether this is the right way to go. I think my education is more from an oncology point of view, and I think if you do treatment beyond progression, as we do it in colorectal cancer, you need to prove it in a clinical trial that treatment beyond progression is meaningful. If you have a second-line treatment available, of course. If you do not have another treatment available, I think it's justified in some cases to continue. But again, and this is also a point we have discussed before, but even with sorafenib, we might harm the liver. So again, here, a careful monitoring of the liver function is important and would need also be considered when we decide to treat patients beyond progression. At the moment, we have a lot of clinical trials. We have an approved second-line drug. So I think, for me, there's no reason more to treat beyond radiological progression.
And how frequent do you image patients?
I mean, if they are not within a clinical trial, we do it every 3 months.